Hello, my dear. I'm Dr. Alaa Mosbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about pregnancy after renal transplant. So, what we want to discuss today, the epidemiology, the complications, the criteria for considering pregnancy, antenatal management and labor management, and what about the breastfeeding, is it allowed or not, and what is the best contraceptive method after delivery. Okay, lastly, the pre-pregnancy counseling. If any woman with kidney transplant need to be pregnant, what you should say to her and what are the important items should be discussed. Let us start with the epidemiology. Pregnancy estimated to occur in 12% of transplanted women of childbearing age. Okay, and in everywhere all over the world, there is increasing number of pregnancy in kidney transplanted patients. Okay, so it is successful. Yes, it is successful and increasing with years. And the incidence of preterm delivery and the preterm premature rupture of membrane and fetal growth restriction is an important complication that may happen, and also acute rejection may happen in 9 to 14% of cases. Okay, what about the most cases of kidney transplant treated with azoxystrobin and prednisone? Is ectopic pregnancy is common? Yes, it can happen with kidney transplant. Why? Because of there is the adhesions from the previous surgery, and some patient has had before peritoneal dialysis, so there is pelvic adhesion, peritoneal adhesions, so there is high risk of ectopic pregnancy also, and you should exclude it early in pregnancy. But the good news is, if pregnancy continued beyond the first trimester, 90% has successful outcome. This is very good news. Okay. Some bad news that preeclampsia may happen and hypertension in up to 40% of cases. Also, urinary tract infection and should be managed properly. Okay. So, what is the complication that may happen? Maternal and fetal complication. Maternal, like hypertension, preeclampsia, allograft rejection, infections, diabetes. Okay. What about fetal complication? Miscarriage, ectopic pregnancy, preterm delivery, intrauterine growth restriction, low birth weight. So, if a woman with kidney transplant asked you this question, when I can plan for pregnancy? Okay, so there must be criteria for considering pregnancy in renal transplant recipients. According to David et al. 2015, according to the guidelines, there must be good general health at least 2 years after transplantation. There is controversy about this point, 2 years or 1 to 2 years, okay? Absence of other contraindications, stable allograft function, I mean serum creatinine below 2 milligram deciliter, no recent episode of acute rejection, no evidence of ongoing rejection, normal blood pressure below 140/90 or equal to, okay, or the patient is controlled with mild antihypertensive drug. Also, there must be absence or minimal proteinuria, I mean less than 0.5 gram per day. Also, by ultrasound, there must be no signs of pelvic calyceal distension. So there is no back pressure, no pelvic calyceal system distension. The recommended drugs during pregnancy including prednisone less than 15 milligram per day, azathioprine less than 2 milligram per kilogram per day, cyclosporin or tacrolimus, and should be at therapeutic level according to the blood serum level. So you should monitor the serum level of this drug. They consider the safest drugs, the safest immune suppression drugs, prednisone, azathioprine, cyclosporin, or tacrolimus. What about mycophenolate mofetil, MMF, and sirolimus? Both of them contraindicated during pregnancy. And also, any woman with kidney transplant planning to be pregnant and she is taking this drug, mycophenolate mofetil, should stop it at least 6 weeks before planning to be pregnant. Okay? So you should advise her. It is contraindicated before and during pregnancy. Okay? And she should stop it if she wanna to be pregnant 6 weeks before planning to be pregnant. Okay? Because it is teratogenic. Many congenital anomalies happen with mycophenolate mofetil and sirolimus. Okay, what about antenatal management? All pregnant transplant recipients should have access to high-level multidisciplinary prenatal care. I need obstetrician, I need specialist in maternal fetal medicine, I need renal physician and the renal transplant surgeon. This cooperation between this team is important, and the patient had the right to access to all of these multidisciplinary specialties. Okay? Close observation during pregnancy, treatment of bacteriuria yearly in pregnancy, follow-up of immunosuppressive treatment, and monitoring renal function and maternal and fetal well-being. Okay? This is important as regards the antenatal management. We should test for certain viruses, especially the cytomegalovirus, HIV, herpes simplex, hepatitis B and C. Also, we should do oral glucose tolerance test to diagnose gestational diabetes. If hypertension happens, alpha-methyl dopa, labetalol, and nifedipine are safe drugs to be used. If severe preeclampsia developed, magnesium sulfate can be used safely. Okay. If there is urinary tract infection in transplanted pregnant patient, this woman should be managed on case-by-case basis between the nephrologist, obstetrician, and the transplant team with support from clinical microbiology consultant as required. What about labor management? What is the time of delivery? What is the best method of delivery? Time of delivery, the best time between 38 to 40 weeks of gestation in absence of any obstetric complication or other complication. Okay? Vaginal birth or cesarean section. Vaginal birth is the preferred route, and prostaglandin and syncytinol both can be given for cervical ripening or induction. You should know that allograft located in the false pelvis, this transplanted kidney located in the false pelvis, doesn't obstruct the delivery of the fetus because the true pelvis is not included. So the belief that this transplanted kidney can cause mechanical obstruction is not true because the kidney in the false pelvis is not in the true pelvis. Okay? So the patient can have a trial for vaginal birth, yes. However, I can say the rate of cesarean section in kidney transplanted women is higher than normal population. Okay, so the indication for cesarean section should be according to obstetric indication or in cases with severe pelvic osteodystrophy. Okay, multiple studies found that the rate of cesarean section is higher than general population, but actually it is not due to just transplanted kidney, but due to the other obstetric problem like IUGR, like development of preeclampsia, like preterm delivery before 34 weeks. Okay, so the indication of cesarean section mostly is due to these obstetric complications. Okay, available help should be ready at any time from the urology surgical team or renal transplant surgeon when elective cesarean section is planned. And nowadays, some centers in USA believe that the urology surgeon should be scrubbed during the operation of cesarean section and should do the midline incision and the obstetrician complete the operation. But this is not yet an international guidelines. But in some center, they do they give this recommendation in their center. But as regard the guidelines, up till now, should be ready under call. I mean, if needed, the urology surgeon. Okay. Okay. Don't forget the stress dosage steroid to be given to women who are on immune suppressive dosage of steroids. This is important for anesthesia also. Okay, what about breastfeeding? Is it allowed to breastfeed or not? Yes, it's allowed to encourage breastfeeding. Transplant recipient taking prednisone, azathioprine, cyclosporin, and tacrolimus should be shouldn't be shouldn't be discouraged from breastfeeding. Okay, so ask her to do breastfeeding and tell her it's safe, no problem with that. But at the same moment, you should know that clinical information on breastfeeding is inadequate for mycophenolic acid, sirolimus, and diplitacid, and breastfeeding should be avoided. So, in certain drugs used, okay, like mycophenolic acid, like sirolimus, you should stop breastfeeding because clinical data about safety is not available. Okay, but if the regimen given to the patient is prednisone, azathioprine, cyclosporin, and tacrolimus, patient encouraged to do breastfeeding. Okay, what about contraception? What is the best contraception? I can say clearly, so long as there is no contraindication, and according to the guidelines, low-dose estrogen progesterone or progestin pill is the best for renal transplant recipients if hypertension is well controlled. Okay? Okay. What about intrauterine device? Is it allowed or not? Intrauterine device has a risk of increased infection because this is immune compromised because of immune suppression. Also, the contraceptive failure that may happen due to reduced anti-inflammatory properties of the IUD. Okay? Due to the drugs given, immune suppressive drugs, corticosteroid, and other drugs. Okay? Reducing the anti-inflammatory property, and this is one of the mechanisms by which IUD work as a contraceptive method. So IUD is not a best choice in transplanted patient. Okay, kidney transplanted patient. Okay, what about barrier method? Barrier method, yes, is safe. It has no risks, no complications, and protective of from infection, sexual transmitted disease as a male condom. But the problem with this method, the potential for contraception failure. Okay, what about tubal ligation? Tubal ligation should be advised in women who have completed their families. Lastly, the pre-pregnancy counseling. You should speak with any lady planning for pregnancy and she is kidney transplanted woman. This must include discussion on the impact of pregnancy on acute rejection and the graft loss. The risk of acute rejection correlate with pre-pregnancy serum creatinine level as well as the interval between transplant and the pregnancy. Long-term survival of the graft appears similar in those undertaking pregnancy to those who don't become pregnant. Really, many studies suggesting that long-term survival, there is no difference between those who become pregnant and those who are not. Okay, so as regard the effect of pregnancy, the long-term effect of pregnancy on the graft, it is appearing to be safe and no problem about that. Thank you. Remember my remember you about my books on Amazon, Obstetrics, textbook of Obstetrics, textbook of Gynecology, and the third one, Contraception Handbook, available now on, on Amazon. And this is the link of my website on Amazon. Okay, thank you.